Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today my topic of discussion is about phacolytic glaucoma. This is the anterior segment photograph of a female patient, 71 years old lady, who presented to us in emergency, and on examination, initial examination, her vision was hand movements in the left eye, right eye, which was operated a few months back. Her vision in the other eye was 20/40. So when she presented to us, her pressure was 45, and the eye was quite congested. And on examination, there was a leukomatous corneal opacity, which can be seen right now in this photograph, and a mature white cataract, plus there was inferiorly pseudo-hypopyon, which is still present over there. This is another photograph, anterior segment. Here you can see that in the arrow 1, it is marked the pseudo-hypopyon, which is present over there, and leukomatous corneal opacity, and pupil is now dilated because of the use of the cycloplegics eye drops, and her congestion has settled down to some extent. This is the corneal examination, slit lamp examination. Here you can see that the anterior segment is well formed. There is no shalving of anterior chamber, and the pupil is dilated, and the pseudo-hypopyon is still present over there. This is the ultrasound on the first day of when she presented to us in emergency. It was done over there to rule out any retinal abnormality, any vitreous involvement. So it was normal, the retina was flat, mild vitreous opacities were there, but there was no sign of infection. So it was a normal B scan. As I mentioned earlier, this patient has already undergone surgery in the right eye for cataract, and her vision is quite good. But this eye, as you can see, has gone a leukomatous corneal opacity. Maybe earlier in the childhood or early years of life, she had some corneal infection, and because of this corneal infection, her vision was poor. So the surgery was delayed in her hospitals because of the poor prognosis. So in such situations, the cataract kept on building up over there, and ultimately she came to us with phacolytic glaucoma, lens-induced glaucoma. Her pressure was high. So this can be the possible explanation of this patient, that this disease, the phacolytic glaucoma, which is nowadays not very common, can still present to you in emergency, provided the patient have some different scenarios, surgery delayed because of poor guarded prognosis, amblyopic eye maybe, and so this delaying in cataract surgery in such situations can lead to sometimes such problems, but which are still manageable. Now let's have a look about this, that when this patient presented to us, what was our initial treatment? As I did mention that we did her examination and investigation, so considering that, we put her on the intraocular lowering agent, topical, that is beta blockers, alpha agonists, and topical and oral acetazolamide, and she was also put in the Bradford eye drops to decrease the inflammation, and dilating drops, cycloplegics, to decrease the pain, break the synecdoche, and control the blood-aqueous barrier. Yes, stabilization of blood-aqueous barrier. So all these things were done, and to control as much as possible the inflammation and intraocular pressure, because it's very risky to go in this situation straight away to do it, because operating such in high IOPs can lead to suprachoroidal hemorrhage and other complications. So we are managing this patient, and hopefully once these things are settled down, some inflammation is controlled, we will go for the surgery. Now let's come towards the different types of lens-induced glaucomas. Lens-induced glaucomas may be because of the lens protein related. For example, as I mentioned, this case, phacolytic glaucoma, where the lens is so much mature that the lens material has leaked from the lens capsule and it is now clogging up the trabecular meshwork and increased intraocular pressure. The other is the lens particle induced glaucoma. Any trauma, any cataract surgery, the lens particles are released which go over there and block the trabecular meshwork. The other is phacoanaphylactic, phacoantigenic, that because of trauma or any surgery, the lens materials are released over there. These released or retained lens material after cataract surgery or trauma, they sometimes induce inflammation, and that inflammation lead to the increased intraocular pressure. Apart from this, there are some aqueous outflow glaucomas related to the lens, which may be phacomorphic, which because of the structural changes blocks the anterior chamber angle, or maybe pupillary block glaucoma. So these are different types of glaucomas broadly which are related to the lens. So as I mentioned, today we are concentrating just on the phacolytic glaucoma. So the pathogenesis is that the cortical lens fibers degenerate into the hydrosoluble protein aggregates. These high molecular weight lens proteins pass through the intact capsule and into the anterior chamber, and when they are induced the macrophage activity, the capsule is intact, but the research has been done, and on electron microscopy it has been shown that there are still some holes or dehiscence where these proteins pass out into the anterior chamber. So these protein laden macrophages plus high molecular weight proteins in anterior chamber, they ultimately do layering over there, cause pseudohypopyon, and they also go into the trabecular meshwork and they cause clogging and blocking of the trabecular meshwork, ultimately leading to the increased intraocular pressure. Clinical features are quite straightforward. The patient presents to you with unilateral eye pain, decreased vision, and on examination you will see there will be mild corneal edema, anterior chamber will be formed, there will be mature white cataract, and there will be layering of this pseudohypopyon you can see over there, and sometimes if you do gonoscopy you will see the angle is open. So these are the findings usually, and to differentiate it with the other entity, as I told earlier, that is phacoantigenic glaucoma, in this case there will be no KPs. Yes, so these are the basic clinical features of the phacolytic glaucoma. So our first target is to control the intraocular pressure. We have to use topical beta blockers, alpha agonists, all these drops, anti-glaucoma medication to control these pressure, along with the oral Diamox. While on the same time we have to put the patient on Bradford eye drops to control the inflammation. Frequently they have to be used. And along with that, cycloplegics, very important to control break the spasm, to prevent the formation of synecdoche, to stabilize the blood aqueous barrier. So all these things have to be done before any surgical intervention is done. That is to control intraocular pressure and control the inflammation. Once the inflammation has been controlled, and if not controlled, it has settled down for some days, and IOP is also some decreased. Otherwise, yani, it will not be possible to bring it to the normal 20s. It will not be possible with topical medication. But just to stabilize it, bring it down, control some inflammation, give it some time. And after that, the ultimate choice is to go for the cataract extraction. That is the important thing. Sometimes there is corneal edema, so difficult to visualize. And especially if you have such patients, as I mentioned, where you have got leukomatous corneal opacity over there. So managing this and doing in hypermature cataracts, doing this rhexis is quite challenging. You have to put the viscoelastics to stabilize it. But even in spite of all these maneuvers, the rhexis can extend, it can cause extension of the tear. Posterior capsular rupture is very frequent in this. So it depends upon the situation. If you are comfortable, you can go with the phaco, that's very good. But if you are not, you can use a small incision cataract surgery or even the extracapsular cataract extraction. So it depends upon the situation. But usually the removal of the cataract and AC wash and all these things are sufficient treatment for these patients, and that is enough. But if this condition is prevailing for a long time, I mean months and months, this condition is prevailing and patient is not seeking the medical care, and he comes to you and there is the drainage channels have been disturbed and damaged, in that situation, in expert hands, where this is a possibility to go for the combined procedure, that is cataract extraction plus trabeculectomy. But that is very rarely required, but possible treatment, especially if the drainage pathways have been disturbed. So the possible complications, as I mentioned, if you go and with high IOP, straightway surgery, very much chances of the expulsive hemorrhage, like these things. And even post-op complications are that it is the inflamed eye which has been operated. So these inflamed eye will persist with inflammation and macular edema. These things can happen later on. So you have to put these patients on the topical medication and cycloplegics and the IOP lowering agent until the inflammation is settled down. And once the inflammation is settled down, these things are gradually tapered off. And usually the results are good, but in all patients who have undergone this procedure, once the corneal edema has settled down, they must undergo the retinal examination, optic disc analysis, to rule out what damage has been done to the optic nerve. That is very important to see over there. Optic nerve analysis, optic neuropathy evaluation, that is also very important. So this was a case which I wanted to discuss, which is nowadays not very common, especially when we have that much facilities. Cataract is being done regularly. So, but occasionally you will find such patients coming to you. So it's very important to differentiate this phacolytic glaucoma from other entities like phacoantigenic glaucomas and their management. I want to thank all of my respected audience for their attendance and attention. Thank you.